Now we'll move directly to the third presentation by Dr. John Ayuk from the UK. It will be a recorded presentation. I have an echo. And to be about
Welcome back,
vitamin
ladies and
D
gentlemen.
for
I would
bone
like to
health and
thank
beyond.
the organising committee for asking me to deliver this talk on vitamin D for bone health and beyond. Again, my declarations of interest, and again, nothing pertaining to this talk. So, going back to basics, how do we get our vitamin D? Most of our vitamin D is generated via sunlight, where in the skin, 7-dehydrocholesterol is converted to vitamin D3, which goes into our bloodstreams. We also obtain some of our vitamin D from our diet, from things such as milk, eggs, and fish. From the blood, the vitamin D goes into the liver, where the first part of the hydroxylation takes place to form 25-hydroxy vitamin D3. This goes from the kidneys, again through the bloodstream, to the liver, where under the influence of PTH, the 1-alpha-hydroxylase occurs, and we get the activated form of vitamin D, which is 1,25-dihydroxyvitamin D3. So vitamin D exists as vitamin D2, which is plant-derived, and vitamin D3, which is animal and sunlight-derived. In the body, vitamin D is rapidly converted to 25-hydroxyvitamin D, and total 25-hydroxyvitamin D has been found to be the best indicator of vitamin D stores in the body. Measurement can be in nanomoles per liter, as we use in the UK, or nanograms per mil, as is used in the US. Measurement is usually done with HPLC or tandem MS assays. So how do we define vitamin D deficiency? I'm sure you'll not be surprised to hear that this is an area of ongoing debate and controversy. There is, however, consensus around a few things. So, for example, 25-hydroxyvitamin D levels below 12 nanograms per mil, which is the equivalent of 30 nanomoles per liter, are clearly deficient. That is accepted. 25-hydroxyvitamin D levels above 30 nanograms per mil, which is about 75 nanomoles per liter, are clearly sufficient. Again, that is universally accepted. The controversy is around the threshold between these areas. So, what is deemed normal vitamin D levels? Some argue that it should be level 25-hydroxyvitamin D levels of 50 nanomoles per liter, which is equivalent to 20 nanograms per mil. Others suggest it should be 75 nanomoles per liter or more, which is 30 nanograms per mil. Some of this debate arises because of a lack of standardization of the assays used to measure vitamin D levels. In the argument around which vitamin D levels should be deemed normal, those who favor the 50 nanomoles per liter or 20 milligrams per mil will often point to the body's physiological response to various levels of 25-hydroxyvitamin D. So if you look at patients or subjects with vitamin D levels above 50 nanomoles per liter or 20 nanograms per mil, in general, you will find the PTH levels are in the normal range and bone turnover is normal. Levels between 20 and 50 nanomoles per liter or 10 and 20 nanograms per mil, often you will find a 15% increase in the parathyroid hormone levels. And bone turnover may still be normal, but may have started to creep up, maybe slightly high. In moderate vitamin D deficiency, there tends to be a further increase in serum PTH and high bone turnover. And in severe vitamin D deficiency, the increase in serum PTH is even further, and these patients will have high bone turnover or even osteomalacia. So how common is vitamin D deficiency? It's generally accepted that the worldwide prevalence of vitamin D deficiency is around 7%. However, this does vary from country to country and from region to region. And as you can see from this slide, in areas like the Middle East, North Africa, Iran, Jordan, the prevalence of vitamin D deficiency is actually rather higher than the quoted 70%. And it's not particularly surprising that vitamin D deficiency is so prevalent. When we think that the main source of our vitamin D is sunlight, and we think about how our lifestyles have changed over the years, we've gone from being hunter-gatherers out in the environment, out in the sun, to endocrinologists sitting in an office, in a clinic, with very little sunshine. The end organ manifestation of severe vitamin D deficiency is rickets or osteomalacia. The condition is called rickets when it affects the growing skeleton, and osteomalacia when it affects the adult skeleton. In both conditions, the bone is unduly soft, and this is due to lack of mineralization of the collagen component of the bone. This arises through a failure to absorb sufficient calcium from the gastrointestinal tract. Rickets or osteomalacia are usually caused by lack of sunlight or dietary vitamin D, but there are a few inherited conditions which in rare cases cause this problem. As well as osteomalacia, other skeletal effects of vitamin D deficiency include reduced bone mineral density, which leads to increased fracture rates. We know vitamin D deficiency leads to secondary hyperparathyroidism and high bone turnover. This may lead to osteoporosis and fractures. Now, these observations are driven by cross-sectional and case control studies in patients who've had hip fractures. And in cohorts of these patients, what has been found is that there's signs of osteomalacia or high bone turnover in up to 30% of patients, and lower vitamin D levels than in age-matched controls. We know vitamin D supplementation improves bone mineral density in older subjects with lower baseline vitamin D levels. But the question is, does vitamin D supplementation actually prevent osteoporotic fractures? A number of studies have tried to answer this question, but to date the results have been very inconsistent. This recent meta-analysis of randomized controlled trials looking at treatment with vitamin D alone versus placebo shows just how inconsistent these results can be. As you can see, the results in favor of vitamin D or in favor of controls fall on either side of the middle. What is also very noteworthy is that most of these studies had a high risk of bias. On the other hand, the same meta-analysis looking at calcium plus vitamin D versus placebo showed more promising results. And in fact, more of the trials suggested that there was a reduction in fragility fractures in the intervention group, the group taking the calcium and the vitamin D. Again, there was a high risk of bias in many of these studies, but certainly in older institutionalized people with lower vitamin D levels, there seemed to be a significant fracture risk reduction when treated with calcium and vitamin D. Vitamin D receptors are widely expressed in the body and, in fact, are present in virtually all tissues. Due to this, over the recent years, there has been a lot of interest in extraskeletal effects of vitamin D. Many diseases have been associated with low vitamin D status. For example, outcomes have been shown to be poorer in many forms of cancer for patients with low vitamin D compared to those who are vitamin D replete. Vitamin D deficiency has also been associated with sarcopenia and impaired muscle strength and falls. A number of autoimmune conditions have been linked to vitamin D and vitamin D deficiency, and also a number of metabolic conditions, including type 2 diabetes. A number of cardiovascular diseases, again, have been shown to have worse outcomes in patients with low vitamin D status. And similar goes for respiratory infections. The question is there a causal role for this? This consensus statement looked at the role of vitamin D in metabolic health. Although the studies are by no means conclusive, a lot of the data they examined suggested that vitamin D supplementation may have a beneficial effect on a number of conditions. They suggested vitamin D supplementation may help with immune system regulation, reduce inflammation, and increase myoblast differentiation. They also found it had beneficial effects in falls risks by reducing body sway, reducing the risk of falling, and reducing the total number of falls. In terms of cardiovascular health, vitamin D supplementation was found to improve blood pressure in combination with antihypertensive drugs. It also showed improved cardiac function with left ventricular remodeling. In diabetes, vitamin D supplementation led to a reduced risk of progression from prediabetes to type 2 diabetes and increased likelihood of regression to normal glucose regulation. Vitamin D supplementation was also found to prevent the onset of obesity and associated metabolic disorders. Now, despite these findings, there are still a fair number of unanswered questions. A lot of these are observational findings, and it's not certain that they can be explained in true physiological or pathophysiological ways. So there is uncertainty around the effects of vitamin D supplementation on muscle mass, strength, and physical performance. And a few other questions arise. So, for example, in cardiovascular health, what doses of vitamin D should one be using? And similarly, what's the optimal supplementation strategy to help improve glycemic control? Of all the extraskeletal effects of vitamin D, cancer and cancer mortality have probably garnered the most interest. This meta-analysis looked at a number of RCTs which compared vitamin D supplementation and placebo for cancer mortality. As you can see on balance, there's a suggestion that vitamin D supplementation leads to improvements in cancer mortality. However, this did not attain statistical significance, and at the moment it is still not entirely clear whether vitamin D supplementation truly does reduce cancer mortality. And how about acute respiratory infections? Now, in 2021, a large meta-analysis of 43 randomized controlled trials of vitamin D supplementation for prevention of acute respiratory infections revealed a statistically significant protective effect of the intervention. The same authors of that meta-analysis then updated the meta-analysis in 2025 with a further 6 eligible randomized controlled trials. In total, they had over 64,000 participants in 46 trials, and these were stratified according to by baseline 25-hydroxy vitamin D concentration and age. And at the end, they found that there was no statistically significant protective effect of vitamin D supplementation against acute respiratory infections, either overall or in the subgroup analyses. So again, as with many of the extraskeletal effects, it's not entirely certain whether vitamin D supplementation does indeed prevent acute respiratory infections. In countries worldwide, there is a lot of debate about screening for vitamin D deficiency in the general population, and also about empirical vitamin D supplementation. This Endocrine Society clinical practice guideline looked which groups of people should have empirical vitamin D supplementation. The suggestion was subjects aged from 1 to 18 years should have empiric vitamin D supplementation to prevent nutritional rickets and because of the potential to lower the risk of respiratory tract infections. Although, as we saw in the most recent meta-analysis, it appears vitamin D supplementation does not reduce the risk of respiratory tract infections. In adults aged between 19 and 74, no empirical vitamin D supplementation is recommended. Although within that group, there will be people who should have vitamin D replacement. For ages over 75, empiric vitamin D replacement is again recommended because of the potential to lower the risk of mortality. In pregnancy, vitamin D supplementation is recommended due to the potential to lower the risk of preeclampsia, intrauterine mortality, preterm birth, small for gestational age birth, and neonatal mortality. And in pre-diabetes, again, based on some of the evidence we've talked about, empiric vitamin D supplementation is recommended due to the potential to lower the risk of progression to full-blown diabetes. As I mentioned earlier, screening for vitamin D deficiency in the general population is also of interest, and the clinical practice guideline did take a look at this. They recommended not to screen routinely for vitamin D deficiency in the following groups: general adult population younger than 50 years old, the general population aged between 50 and 74 years old, general population aged 75 years and older, during pregnancy, in healthy adults, in adults with dark complexion, and in adults with obesity. So many groups are excluded from population screening, which I suppose is a sensible thing. However, what you will note is the basis on which these recommendations were made relied on rather weak evidence. So to summarize, unfortunately, there remains a lot of confusion around vitamin D, and I suspect my talk will leave you feeling more confused rather than less. Confusion centers around target levels, non-classical effects, and public health versus disease, etc. The strongest evidence is around bone health, but even in this setting, the only really proven benefit is in older institutionalized adults with low vitamin D levels. There is an issue with vitamin D preparations and dosing, and this is one of the reasons why many of the studies around the impact of vitamin D supplementation show inconsistent results. There are multiple disparate guidelines around. There are American guidelines, there are European guidelines, there are country guidelines, other region-wide guidelines. So it's sometimes difficult to know which ones to follow. The good international guidelines, however, do actually help clarify good practice, and where there is not good evidence, they do use pragmatism to provide reasonable recommendations. Listening.